We will conclude our discussion of the pathology of the lymphoid system with a discussion of plasma cell neoplasms, and then follow it with a discussion of the pathology of the spleen and of the thymus. So plasma cell neoplasms, you need to think about what is a plasma cell to start with. So a plasma cell is a white cell that secretes immunoglobulins at baseline. When they are disordered, they can produce a monoclonal overproduction of a specific immunoglobulin subtype. So plasma cell neoplasms include plasma cell myeloma, plasmacytoma, MGUS, which is the monoclonal gammopathy of undetermined significance, or lymphoplasmacytic lymphoma, also called Waldenstrom's macroglobulinemia. So the plasma cell neoplasms secrete an intact monoclonal immunoglobulin, or the M protein, as well as free heavy chains or light chains, and the free light chains are called the Bence-Jones protein in the urine. What you see here is a serum electrophoresis pattern on the bottom part of the slide, where you see a normal protein electrophoresis on the left-hand side of the slide, and a monoclonal gammopathy in the gamma globin chain of the electrophoretic pattern there. And that is oftentimes a monoclonal peak, so it is a specific type of gamma globulin that is hyperproduced from the malignant clone. So plasma cell myeloma is increased abnormal plasma cells with this monoclonal gammopathy, which are primarily produced by lesions within the bone marrow, which produce lytic bone lesions, as pictured in the skull X-ray on the skeletal survey seen at the bottom of the slide. Morphologically, a plasma cell myeloma produces sheets of large abnormal plasma cells with IgG inclusions, and you can see those in the bone marrow, and those are seen on the bottom part of this slide. So you can see a plasma cell as having an eccentric nucleus with a paranuclear halo, which is the Golgi apparatus, which is secreting those immunoglobulins in significant numbers. So the pathology of multiple myeloma, or plasma cell myeloma, the symptoms are produced by bony infiltration, which can cause both chronic pain as well as pathologic fractures. Furthermore, hypercalcemia can be manifest by the increased bone turnover, and you can have bony pain, you can have kidney stones, and you can have vague abdominal pain from hypercalcemia. So seen together, elderly patients with hypercalcemia and back pain need to be worked up for myeloma as a primary part of your differential diagnosis. If you have increased immunoglobulin production, that can cause renal failure as well as deposition of amyloid protein in the parenchyma of really any tissue, but most importantly in the heart and in the kidneys. You can have impaired immunity with recurrent infections from impaired immunoglobulin synthesis. Though you have hyperproduction of gamma globulins, none of those gamma globulins are appropriately directed against any particular organism. So the immunoglobulins you're producing are essentially ineffective. Plasma cell myeloma is almost exclusively a disease of the elderly, so greater than 50 years, with incidence increasing with age beyond the age of 50. The prognosis is remarkably poor. The median survival is about 3 years, even with treatment. In contrast to multiple myeloma or plasma cell myeloma, where there are sheets of plasma cells, a plasmacytoma is a solitary lesion consisting of one clone of monoclonal neoplastic plasma cells. It can be seen in bone, it can be seen in soft tissue, and it can even be a precursor lesion to a plasma cell myeloma if left unchecked for a decade or two. So extraosseous plasmacytomas can be seen and rarely progress. They can be surgically cured if completely resected. Another important thing to consider in the spectrum of plasma cell myeloma, plasmacytoma, is the monoclonal gammopathy of undetermined significance, which has a monoclonal M protein but no signs or symptoms of myeloma, so no back pain, no bony lesions, no hypercalcemia, and this can be found in up to 1% of people over the age of 50, and again, like multiple myeloma, that incidence increases with age. The treatment of monoclonal gammopathy of undetermined significance is often watchful waiting, as only a small percentage will progress to overt myeloma, about 1% per year. Lymphoplasmacytic lymphoma consists of neoplastic B cells that can secrete a monoclonal IgM. And if you remember, IgM is oftentimes a pentavalent or 5 Ig proteins dense that can cause a hyperviscosity syndrome depending upon where that hyperviscosity is occurring. If it occurs in the brain, it can cause neurologic problems. If it occurs in the vasculature of the eye or the retina, it can cause visual impairment. And it can also cause bleeding with that associated hyperviscosity. Patients can present with hepatosplenomegaly or some profound anemia with associated lymphadenopathy. Lymphoplasmacytic lymphoma is progressive and incurable, and the median survival is about 4 years. So a discussion of the pathology of the spleen also is important to consider in any discussion of the lymphoid system. So the spleen is located in the left upper quadrant, and the primary pathology is manifest when the spleen gets big. So splenomegaly can be caused by passive congestion, either portal vein thrombosis or cirrhosis, any type of portal hypertension, so elevated pressure in the portal venous system, can cause passive congestion of the spleen. Similarly, heart failure, where you'll have basically congestion of the entire venous return system, you can have splenomegaly from that as well. Or you can have infiltration with lymphoproliferative disorders, or storage diseases and amyloidosis can also manifest as splenomegaly. One of the important things to consider in splenomegaly is there infection with Epstein-Barr virus as well, because that can cause very painful splenomegaly that is prone to splenic rupture. So congestion of the blood in the spleen, or hypersplenism, can cause sequestration of the blood elements and therefore a secondary thrombocytopenia or leukopenia if those blood elements are sequestered in a large amount within the spleen. It can also cause activation of the reticuloendothelial system, those macrophages in there that help the spleen do its groundskeeping process of the hematologic system. In some cases, with passive congestion of the spleen or reactive congestion of the spleen from Epstein-Barr virus infection, there's an increased risk for traumatic splenic rupture, causing potentially fatal hemoperitoneume and massive amounts of blood loss. So that's why college athletes with Epstein-Barr virus infection or infectious mononucleosis have to sit out 6 weeks to an entire season because they're at increased risk for traumatic splenic laceration and rupture. The last organ to consider in a discussion of the lymphoid system is the thymus, where a lot of the lymphoid tissue has its maturation. So disorders of the thymus that you could be tested on include DeGeorge's syndrome, which is thyroid hypoplasia and parathyroid hypoplasia as a result of agenesis or disordered genesis of pharyngeal pouches 3 and 5. Or a thymic cyst, which is a usually incidental finding. So DeGeorge's syndrome has the constellation of hypocalcemia from parathyroid hypoplasia and immunodeficiency from an inadequate formation of the thymus. There can be thymic hyperplasia in chronic inflammatory and in immunologic states. And in thymic hyperplasia, it can frequently accompany myasthenia gravis, which is an immunoglobulin against the motor end plate, acetylcholine esterase receptor. So those are the common pathology findings in the thymus. A thymoma is a tumor of thymic epithelial cells, and those can either be benign or encapsulated, or you can have an invasive malignant thymoma or frank thymic carcinoma. So you can get a cancer of thymoid tissue, which can be relatively invasive to the surrounding tissues. Clinical features of thymomas are associated with hypogammaglobulinemia, as well as Graves' disease, red cell aplasia, pernicious anemia, a lot of these autoimmune disorders that you're seeing here. So Graves' disease, pernicious anemia, and dermatomyositis are all considered autoimmune disorders. Graves against the thyroid, pernicious anemia against the parietal cell that produces intrinsic factor, dermatomyositis and polymyositis against some of the muscle cells, and Cushing syndrome and autoimmune destruction of the adrenal axis. So the simulator question for step 1, a 61-year-old male complains of back pain for several months, and a skull radiograph demonstrates punched out lesions. You see BUN and creatinine levels that are found to be rising. A bone marrow biopsy would most likely show, this is clearly a question that's asking about plasma cell myeloma, so you're looking for what you would try to see there. So you would see numerous plasma cells in the answer to this question. So this is a gentleman who's manifesting the symptoms and signs of plasma cell myeloma. That concludes our discussion of pathology of the lymphoid system. Hope you'll pay attention to some of the next discussions.